Hello. The title of my topic today is Are Dental Alveolar Changes an Artifact of Two-Dimensional Radiographs? I'm posing the question that when you compare two-dimensional cephalometric radiography to cone beam CT, are dental alveolar changes as we currently understand them nothing more than an artifact of looking at two-dimensional radiographs? My name is Jeffrey Miller. I graduated from Towson University, did my dental school training at University of Maryland, got my orthodontic certificate at SUNY Buffalo, and I've been in private practice for 31 years. If you take a look at this photograph of the gentleman in the white t-shirt, would you say that he's exhibiting normal behavior? But your assessment is based on a two-dimensional photograph. You don't have the ability to walk around him and see him in all three planes of space. If you did, you would see that he's wearing a Bluetooth headset, which would change your assessment of his behavior. Just like this photograph, two-dimensional radiographs just offer a view of one plane of space. It does not give you the ability to walk around the subject and see it in all three planes of space. Cone beam CT allows you to not only view the object in all three planes of space, but you can slice through the object, eliminating all the superimposed structures so you can get a clearer view of what you want to look at. When we look at a two-dimensional cephalometric x-ray, we're really looking at a composite view of the anterior teeth. You really have no idea when you trace out that cephalometric x-ray is if you're tracing the bone that relates to the cuspid with a lower incisor, central incisor, or vice versa. You're looking at a composite view and really only tracing the outer borders of the bone. If you take a look at this patient here, this was really just a miserable case. This is 7 years post-treatment. We extracted 4 first bicuspids. She ended up losing the upper laterals, so we moved the cuspids in for substitution. We told her she was going to lose the upper centrals. We splinted the teeth for her, so she to buy her a little more time. It was just one disaster after another. We know that she's going to lose those upper centrals. You can tell from the reconstructed panorex that there's just no support for them. But what about the lower incisors? The lower incisors appear to have shortened roots, but how do they appear to be in terms of bony support based on the pan and the cephalometric x-ray we have here, or the reconstructed cephalometric x-ray? If you take a cone beam CT and slice down the center of the lower central incisor, you get a completely different view of the bony support for that individual tooth. Here we have the same patient on the left, a 77 millimeter focal trough compared to a 0.2 millimeter focal trough on the right. And you can see, if you were to imagine tracing the reconstructed cephalometric x-ray on the left, you would get a completely different perspective of the bony support for individual teeth compared to the 0.2 millimeter focal trough, which eliminates the superimposition of all the structures, so you can see the relationship between the incisor and its bony support on individual tooth basis using cone beam CT. This is a patient came in 25 years post-treatment. She came in because she had a broken lingual fixed retainer. Now, she started as a class 2 division 1. She was treated as an adult. We recommended orthodontic surgery. She declined to have the surgery, so we extracted 2 upper first bicuspids and treated the case that way. Now, based on this reconstructed cephalometric x-ray, how would you assess the bony support for the lower incisors? Well, if you were to trace that cephalometric x-ray, it would appear that the lower incisors are in pretty good bone. You might say they're proclined a bit, but overall they look pretty healthy. However, when you reduce the focal trough and look at tooth number 26 on an individual basis, you can see that this tooth was pushed through the limit of the cortical plate. It's a boundary violation. You have no way of knowing what happens on an individual tooth per tooth basis when you're using two-dimensional cephalometric radiographs. So when we talk about dental alveolar changes being an artifact of two-dimensional radiographs, this is kind of what we're looking at. We trace a composite view of the anterior region, and because we're tracing a composite view, it appears that the tooth is centered within the alveolar bone and that there's a flexure or a remodeling of the alveolar process that supports those lower incisors. But really, most likely the teeth are moved through the bone. Why is this mission critical? Well, it's mission critical because as orthodontists, if we push the tooth through the cortical plate, we're going to create dehiscence or fenestration. Bone does not grow or remodel at the cortical plate. If you remember back from your histology, you get osteoclastic activity on the compression side and osteoblastic activity on the tension side. Well, that's fine as long as the root is moved through the bony trough or the bony highway. But once you start putting buccal or lingual forces on the tooth, you only get compression on the leading edge of that root, which creates osteoclastic activity. It's not realistic to think that that osteoclastic activity somehow converts to osteoblastic activity because there's no opportunity for tension on the leading edge of that root. This diagram kind of explains what I believe happens when we create orthodontic boundary violation. This represents all three views. The top is the sagittal, the top is coronal, the middle is the sagittal, and the bottom is the axial view. From the coronal view, you don't really see any bony changes because the height of the crestal bone does not change. But from the sagittal view, if you go from the left to the right, you see that we have the tooth centered within the alveolar bone. We have the orthodontic force which creates the orthodontic boundary violation, and then you get an adaptive resorption of the lingual bone to adapt tightly to the root of the tooth. This adaptive resorption seems to be most relevant in the anterior regions. If you look from the axial view, you could see the tooth is centered within the alveolar bone. Then it goes, you have the orthodontic boundary violation. You get interseptal bone changes or a flaring of the bone to help support the tooth because of the interseptal bone, because you still do have tension in those areas. And then you get adaptive resorption of the lingual bone in this case. So the tooth still looks like it's centered in the alveolar process, but it actually was pushed forward through the bone. So when you trace it on a two-dimensional radiograph, it appears that the tooth and the alveolar process came forward, where really it was just the tooth and the root that came forward, and you get adaptive resorption on the lingual surface to make it look like it's centered. Here's another example. If you look at the far left, you see that this is an orthodontic boundary violation from excessive class 2 elastic wear. You can see that the lingual bone still exists on the left, and as the tooth stays there over time, that bone resorbs and you lose you get a tightening or adaptation of the lingual bone of the displaced tooth. This case was a class 3 growth case. They didn't want to do surgery. We were trying to correct it as best we could using orthodontics, and you can see from the photographs that the teeth were lingually displaced. Take a look at its cone beam CT. You can see how upright the teeth are. But when you look at the axial view, you can see that there's boundary violations here. The roots of the teeth are pushed through the limit of the cortical plate. You can see the flaring of the alveolar bone, or the alveolar process, as a result of the interseptal bone changes. This is a case that came in 15 years post-treatment. She came in because her lower fixed retainer was broken. If you take a look at the reconstructed pan and ceph, everything looks completely normal. If you were to trace that ceph, there would be nothing unusual. But if you look at her clinical photos, you can see that she has some generalized tissue stripping. Now, is this a result of a boundary violation or a thin gingival biotype, or a combination of both? What I would suggest is the patients with the thicker gingival biotypes just hide the bony defects better. They're still there, they're just hidden. Years ago, before cone beam CT, when I would see something like this, I would put brackets on and try to reposition the tooth over an area of thicker bone based on a two-dimensional cephalometric x-ray. It probably was not a good idea, because if you think about it, you get an adaptive resorption of the lingual bone, and this is the same patient you just saw. There's really no place to reposition that tooth. The lingual bone adapts to the root of the tooth. So to try to move the tooth back lingually over thicker bone based on this two-dimensional radiograph is probably not the greatest idea. Because where are you going to move that tooth? Where it's in better bone? You can't. I'd like to thank you for listening. If you have any questions or comments, feel free to email me at ortho606@gmail.com. Thank you.